对姐姐，哎，我说我们这可以站这儿看这个，可能清楚一些。就看，
哦
就跟我站一块。
We are ready. We are ready.
听一下，它声音蛮小。这里面有没有声音？有。那我完全听不到。声音能不能调大了？声音蛮小。让他们调一下。那个工程师声音好小，这边。里边那个。好，就耳麦的声音很小，他们那边现场的声音。可以开始了。
Hello. You are ready here in Cairo.
就好了嘛，这个屏幕打开。
Dear friends in China.
他们放到哪里了？也不知道他们在看啥。这球。
Yes.
可以放到这里。
Yes.
可以听到是吧？
Yeah. What are you going to do?
你看你那个。现在没。
Dr. Jia will start artificial intelligence assisted upper gastrointestinal endoscopy. Okay.
在我旁边。把门关上。为什么只有一个耳朵？啊？声音好小，还是声音蛮小。我听到。我这里面什么声音都没有，你那儿有声音吗？没有。不要紧，我到时候要是没听到，我就要刘兰老师在这里面再翻译一下。听不见，你说话我能听得见吗？你不用翻译了吗？不用，因为我不用了，你就待着了。试过了就行了。啊，他们会因为现在全部都远程操作呢。这边开始了吗？不知道。我现在那个。哎，我们现在说话，对方能不能听得见呢？
这边说话，对方能不能听得到？可以。
Dr. Zhu.
Hello?
Hello?
We
Yes?
are ready in Cairo here for the first transmission. Dr. Ni will start. Please explain to us what you will do.
Okay.
Thank you.
I'm ready to start.
I'm ready to start. Good afternoon, everyone. I'm Jia Lian from Wuhan University Hospital, Zhongnan Hospital. Today, I'm going to demonstrate AI-assisted upper digestive tract endoscopy. The instruments is a 700 Fuji endoscopy and AI system from Helan Xuanwei Tang Medical Information Technological Company. Let's begin. From the ulnar cavity, I like to use LCI mode. Our Fuji endoscopy, the unique color enhancement made it very helpful to find the lesions. In the esophagus, I focus on three structures. The first structure is esophagus entrance. The second is the follication of left and right bronchus.
Excuse me.
Oh, they have a formal.
I will
I will
report.
clear it.
对，叶家燕讲一下，是不是跟你们说一下吗？是不是小叶？我还没到背史，他就开始讲了，他没。
I think these people have
等着去讲话回来
reflex
了。
esophagitis. Then I was switched to BL Bright, BLI.
这边讲了，现在男的是讲了。Okay, I will give you the general information of this patient. This is a patient of 72 years old, male, teeth plain, vomiting for 1 month, no previous medical history, and the diagnosis is suspected gastric mucosa associated lymphoid tissue lymphoma. Upper gastric endoscopy showed 1 plus 1.5 centimeter ulcer on the posterior wall of the upper gastric body and reflex esophagitis. Biopsy showed chronic gastritis and severe intestinal metaplasia. This procedure is AI-associated magnifying endoscopy and will be performed by Professor Jiayan Ye.
In there, I can see a lesion. Now I use BLI Bright. Use ME to observe this lesion. I think it's intestinal metaplasia.
Excuse me.
Yes.
Yes.
As far as I understand, you use a computer to diagnose what you see. I'm right?
那你是不是在用那个 AI 就是辅助的？
Yes. Look at this AI system produced by Helan Xuanwei medicine confirmation technological company. Look here, there is a stomach model. The red color indicates that I have taken pictures, and the blue color present the area I didn't take any pictures.
他们看不看得到？
Look here, I can see the epithelial is P1.
Professor Ray.
Good morning.
Good morning, sir. Is it a sort of artificial intelligence? Because it is difficult to follow.
Yes, it's a beginning of a new tool. And I think, it's important now with real view. Because when you use LCI or NBI, the artificial intelligence sometimes is more difficult to use. It's why it's better to use with a white light endoscopy. But it's very different from one tool to another. I will explain later on this morning.
Thank you, sir.
They have mucus. I will first clear it. There is ulcers. Oh, everyone, look at the AI system. Now we can see the red color. It indicates that it's possible of a tumor. Now we switch to BLI. I use BLI to BL bright to observe the smart surface microstructure and microvascular.
你是翻译吧？
我帮忙。
哦，那你稍靠近一点，待会儿我跟他们一起。靠近。
The microstructure, I think, is irregular. Because the mucus, I can't see anything in the middle. I will flash it. Oh, breathing. Flash the former, flash the mucus. I can see irregular vessels.
是血管吗？他看我这上面是那个灰尘血管。对。好像说是一个灵魂，lymphoma。
It's easy to bleed, so I must make what to clear it. To use what to clear it. Now we're going to observe the stomach. Generally, I will check the stomach, follow the posterior wall of stomach. Then the lower part of stomach. Look here. The Fujin 7000 have the LCM mode. This mode is very helpful for our to find the lesions. The red color indicates that there has intestinal mucoplegia. And the purple color indicates inflammation and HP infection. But we put back to look at the answer. In LCI, with LCI, the color usually is reddish or yellowish red or purplish red. In the stomach, we usually take 24 pictures. We will observe any part of the stomach, the laser vector, the posterior or the great curvature, the posterior curvature. We will pass the pylorus to observe the duodenal palmar.
Anterior.
We use black pepper, so it's difficult to pass it. Not have any lesions, so we will continue to observe the descending duodenal pattern. Now we take back to stomach.
Professor Nie.
Hey.
I'm Dr. Chen from Shanghai Hospital. I remember 2 months ago, there is a competition with 50 doctors from China with AI. You got a very good place in this competition. Congratulations. So,
Thank you.
to this answer, you think this is a tumor?
I think yes, I think it's it's a tumor. Probably it's a undifferentiated cancer. I will give a deep biopsy.
But the tumor is now bleeding, so it is difficult for you to
It's possible. It's possible.
check it again, I think.
But it's impossible. Informal, multi-informal.
Oh, so do you think there is demarcation line of this lesion?
No, I can't see DL.
This is a different from the lymphoma and the cancer, I think.
The stomach lymphoma always have the typical topical features. The first one is the tree-like appearance. The second, it always have a HP infection mucosa background. And the microstructure is also appearance.
Excuse me, please. What have you gained from the use of artificial intelligence here? Are we sure of the nature of this gastric ulcer?
I think it's Tuesday ulcer. I think it's a decline. It's malignant. 恶性。哎呦，出血了，我先看不清楚。
Dr. Nee, what makes you sure that it's a malignant ulcer? Are you sure?
你怎么确定它是一个恶性的？就是怎么让你认为它是一个恶性的？
Because first, this is a old man. Two, it has a HP infection background. The third, I can see the microstructure. Microstructure is irregular, and the microvascular is Oh, sorry, it's bleeding. I can't see anything.
You have black cap in the front of the scope?
Dr. Nee, it looks malignant, but should you take biopsy as well? Is biopsy important here, or you final diagnose as malignant ulcer or mass?
Give me some words.
I would like to make two comments. It's a nice examination to show the efficiency of BLI, and BLI is like NBI. So we could see the abnormality of the pit pattern. We could see a regular vessel. And from my personal point of view, for a large tumor like that, artificial intelligence did not add a lot compared to the usual Fuji, BLI, and LCI, because it's more important to use artificial intelligence for detection, and in that case, it's so large that we cannot meet. And for characterization, it's more important than stomach for characterization of small superficial gastric carcinoma, especially to look about malignancy and delineation in order to do ESD. For large tumor like that, routine Fujiscope with a BLI and LCI are quite important. And artificial intelligence did not add quite a lot. But it's a totally new field, and you have to adapt the artificial intelligence tool to stomach, esophagus, and colon. We cannot use the same software for all the digestive tract. We have to have a specific software, and it's more important for tiny lesion and for superficial gastric carcinoma. But definitely the endoscopic aspect is a malignancy. This is LCI, and LCI is important to enhance abnormality. And you see, in that case, you have intestinal metaplasia enhanced by the LCI. The LCI is equivalent to TXI from Olympus, just released last year. It's well demonstrated, and that's live demo. And you see the border are irregular, and when professors show with NBI, you have a lot of abnormality. The pit pattern is irregular, and the vessels are disappearing or irregular too. This is the aspect with the LCI. And you see with LCI, the border and the margin are easier to see. Yes.
Now I'm going to give a biopsy.
Dr. Francois, is the techniques they are using just for detection or for diagnosis?
But by the time being, I use the artificial intelligence only for the colon, because they develop some artificial intelligence for the stomach, but in the West we don't have a lot of early gastric cancer. So the tool that I will talk later on this morning is just specific for the colon. I don't use artificial intelligence by the time being on the stomach. It will be important to use artificial intelligence in Egypt or in France for Barrett esophagus. But you have to understand each organ, each pathology need to have a different tool. You cannot have one artificial intelligence for everything. It's not like scope. When you have Fuji scope or Olympus scope, you could use upper GI, lower GI. For the artificial intelligence, you need to have a specific module for colon, specific module for stomach.
But artificial intelligence is used only for detection of the lesion?
No. Artificial intelligence are using for detection, but also for characterization.
What's the difference between characterization and diagnosis?
No, characterization is to make accurate diagnosis about, the malignancy, non-malignancy, and the delineation in order to do ESD. So with artificial intelligence, you make a very accurate diagnosis, so you don't need any more pathology. For example, in some lesion, we do biopsy and later on we remove. In that case, using artificial intelligence, you detect, you characterize, and with characterization, if you think it's suitable for removing by endoscopy, you do ESD, and you send the specimen, total specimen, to the pathologist, like a double surgeon.
And I think after we took the biopsy, we think the lesion is malignant because we can see the mucus is very stiff, not soft as usual.
Perfect. Yes, you are totally right. It's well demonstrated.
So the whole lesion looks like stiff, not soft when we absorb the air.
But Dr. Francois, don't you think that using the artificial intelligence abolish the human brain, stop the human brain from thinking?
Oh, yes, of course, you know, and what is important with artificial intelligence, it gives you more accuracy, because we have an excellent endoscope for the last 10 years, and sometimes people don't use properly and miss the correct use of LCI, NBI, and so on. Artificial intelligence will increase your accuracy and give you a better overall endoscopic quality.
It's still, there is a chance for machine error. Do you think that still there is?
Of course, you especially for detection. Especially for detection, we have the machine error. So we have a lot of, depending on the software, we could have a lot of false positive. But for characterization, and especially had been developed by Shenyo Kudo Group, is quite very high accuracy.
Now we can see there are some brownish area. So when we see the brownish area, we usually will use the magnifying endoscopy to judge the lesion. And now we can see on the magnifying endoscopy, we can see the IPCL. And this is the B1 style IPCL. It can be inflammation or low-grade dysplasia. But we can see the deep
ulceration here.
There's no demarcation line of this.
Yeah, no demarcation line. That's right.
Dr. Francois, the artificial intelligence is still not excellent for diagnosing early gastric cancer.
Oh, yes. It's we have some paper from Japan where you could see the importance of artificial intelligence for detection and characterization of early gastric cancer. But it's more well developed in Japan, in China, because they have quite a lot of early gastric cancer that we don't have a lot in Europe or in Egypt.
Can artificial intelligence guide the gastroenterologist to the treatment, to the line of treatment? Can advise the gastroenterologist to do certain procedures?
Yes, of course. And it's more well developed in the colon than the stomach.
So we have finished the examination, and we can see from the AI system, we have detected all the esophagus and stomach. So you can see all the stomach and esophagus become red. The blue color means we didn't undetected. We didn't take any picture.
Thank you very much.
Very good.
Thank you.
Thank you. Okay, now we will start the second demonstration. Please touch the medical history of this patient.
Case number 2. This is a 60-year-old female patient. Chief complaint intermittent nausea and vomiting for 1 year. Previous medical history, no significant. Diagnosis is cardiac achalasia. Upper gut endoscopy showed narrowing and shrinking of the cardia. EUS showed thickening of muscular layer, about 3.7 millimeter. X-ray also showed narrowing and shrinking of the cardia. And this procedure is POEM, and it will be performed by Professor Guiqi Wang.
Can you tell us the lesion you are doing this procedure for it?
It's achalasia.
Achalasia.
Achalasia, yes.
Yes, okay.
So
you are going to do POEM.
We have detected the pressure of the esophagus and make sure it's alexia.
Okay. 回来啊，哎好 ，OK， 哎 ，OK， 行了，进来，回来，别着急，非常棒 ，OK。我现在在单位踏板我都不踩，我就光动点手。我说我现在在单位尝试，我连踏板都不踩。回来，哎。
So we can see we have entered the submucosal layer.
这个病人。
And Professor Wang seldomly used the agricultural forks. He usually used the knife to coagulate the visible vessels.
好，别着急。我做手术很少用通气通水按钮，不通气也不通水。 对，血管。
The right side is the muscular layer, muscle layer.
回来。回来。
And during the performance, we need to avoid injure the mucus.
好，非常好。快到了。
So the tunnel is almost done.
对啊，像我这是食管的可以了，我得现在正好到食管下括约肌这儿，马上到这个这块就比较窄了，这最明显的，我觉得我个人啊，
这里是贲门了吗？
啊，这贲门了，我现在要到。
Okay, now we have reached the cardium.
这病人可能病史比较长了，整个食管都很淤曲了，从食管入口我看就扩张的很明显。
Because the patient has a long history, so we can see the esophagus is not straight.
好，非常好，不着急，不着急，着急 ，OK， 好。 OK， 好。回来。好。
Now we can see the life is always near the mucosal layer, and to avoid to injury the mucus. Mucosal layer.
回来，不着急啊。
对啊，用的丢刀嘛。
就是丢刀。
Professor Wang, we will ask some questions. Where to establish the tunnel and you
基本到胃底了，直接到胃底了。跟人说到胃底就 OK 了。还要看一下。大概是从最狭窄的地方再交一下10公分吧。
Please tell us the length of the tunnel.
回来啊！OK， 完事儿，我们基本上就从这儿，我们就是主任看，这是应该是最狭窄的地方，我们把这一切断。
怎么搞？嗯？
回来。
Professor Wang start the perforation from the 10 centimeter from the structure.
这会儿慢一点啊，这是黏膜。好 ，OK， 基本上差不多了啊。这是回来。大家看，就是我的隧道，这的大概是38啊，这是我打的隧道一直在走。
桂奇教授。
开了是吧？哎，您好。
哎，对呀，我是令荣。哎，我是令荣。
你好，令主任。
哎，我跟陈杰教授和徐灿教授在一起。
这个赵主任让我做个泡沫，我就来露丑了啊。
没有，做的特别好，看得行云流水。
因为我很少做泡沫，但是正好有个学习的机会吧，哎。
没有，做的非常好。正好桂奇教授，因为我来的有点晚，我可以没有看得特别清楚。那个像我们 poem 的话，不是分3型吗？然后大概每一型的这个，我们在决定切多长的话，您有什么心得吗？就是大概。
这个你算问错人了，我对这方面真是不是特别了解。我1年大概做了2、3个，我做的都是肿瘤，但今天来这正好学习吧。但是就是这个病人确实是，我觉得还是病史蛮长的，出来。
血管很丰富。
We're talking in Chinese.
宁教授，如果你可以的话，那个埃及那方面，希望你用英文提问。
出来啊。
Will you please speak in English just to allow us to follow you?
Okay. Now we begin to perform myotectomy.
出来啊！我用拧给它切开了，然后我就开了。
وصلوا بعد
肿形肌。OK， 好嘞。不着急，不着急，真的不没事。对他那个，只要你看好层次，你不要去向那里去弄它干嘛？它没意义，对吧？让长主任说话，我就是。
Now we can see we almost done the full thickness
这是最狭
dissection.
窄的地方，视网下柜最狭窄的地方。晚上我们就进到胃底了。开了，最狭窄的位置。够开了，对吧？
So Professor Wang, now you use coagulation or just cut mode? 您现在是用的切的模式还是用的零的
切之后我就用
coagulation? OK.
因为这块。
When we did the myectomy, we usually use the coagulation mode.
OK. 到这里能到哎上，整个环形肌、肿形肌都切开了，就 OK 了。大概我切了有7公分长吧。 到这儿已经是15了。
How do you decide where is the end of the
进到胃底就 OK 了。
OK。
进到胃底就 OK。我再从食管这儿来看一下，大家看这应该很轻松了，对吧
？OK。
非常轻松的就。
Yes. Now the pressure is become low, so we can put the endoscopy easily.
看过来就是 OK 了，因为这块已经。 剥离到这儿了，我可以再往下再走一点，往下再走1公分吧，1、2公分 ，OK 了。从整个来看，一点阻力也没有了啊，非常容易啊，非常容易啊，非常容易。
When we put the endoscopy, there is no obstacle, no force.
我再来点。
So，
注射液，我稍微再往下走一点点，再往下走一点。
Further 1 centimeter.
Yeah.
Okay.
我这手呢，你看我也最低的气量，我手呢既不通气通水，我也不负压吸研究，不消气的，就自然的这种让它去 OK 了。
Professor Wang said, when we do this performance, we didn't need to put too much air.
哎呀，这而且是最低的一个流量，非常重要。这个对于由于做
and this is very important.
好。完事儿。 回来啊，回来。
Hello, could you use on the type of knife you're using and the current settings?
Okay, this is dual life from Olympus company. And the life is forward, the top is forward.
OK， 出来，知道。
So, how common is perforations in your experience doing poems?
Sorry?
The incidence of perforations, esophageal perforations, how much?
I think usually we didn't care whether it's perforation or not. because we usually do the full thickness dissection. So, and we think this is more effective for the patients. After the operation, the patients will not present the structure anymore. So, and you can see we do the full thickness dissection, not just the upper layer.
我再把这血管处理一下
Work in
这儿了。
one cost. I mean,
热
yeah,
柔和
under 20 minutes so far.
再看，
Yeah.
好，完事儿了。我就是处理一下创面。
Now we coagulate all the visible vessels. 这个很累，这个不用再。
我觉得没必要去弄它。
啊。
弄它，整直，我觉得没必要去弄它。OK， 好像。
So Professor Wang is the master of the ESD.
Okay.
He just done this performance in just maybe 50 or 20 minutes.
Okay. 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 好。那不用去弄它了，
下面
太深了，那太不没一点没必要。
啊，
没必要。OK。OK。 没什么问题了，那我们就准备去。
Okay, now we have to check all the visible vascula.
和。黏膜能不去处理就不去处理的。
And we need to make sure the vascular layer is intact.
这个还要处理，张开。和。OK。
Okay, now we will close the wound.
来 ，OK，close， 很好了，已经。
Yes。
非常。
Really, congratulations. It's a very fast procedure in your hand. Very well done and fast.
Yes, thank you. 康宁做得好。
谢谢。没有，我这也是来学习。
Now we will use the fork to close the wound.
张开，不着急，小伙子，不着急。
Trying to do the closure of the track.
Sorry.
You're
closer with clip.
转一下，别着急。好，合上点，不着急，不是合上点，合上点，不着急。你合打 ，OK。
Thank you, Professor Wang. Thank you for the wonderful procedure. So we'll move to the next case. Thank you.
Okay, thank you.
Thank you very much from.
Thank you.
Thank you. 谢谢。
Excellent work, Professor. And very nice and rapid procedure.
OK， 好的，非常好。没有，我就没做过，我来学习来了，就是，没做过这个东西，露怯了。
You will move to colonoscopy now.
Okay, we will go to the case number 3. This is a 70-year-old female patient, chief complaint, diarrhea for 3 months. Previous medical history, no significance. The diagnosis is colon polyps. Colonoscopy showed 6 plus 8 millimeter polyps on the circum and multiple 2 to 3 millimeter small polyps on the rectum. We will do AI-assisted colonoscopy for this patient, and it will be performed by Professor Jing Liu. AI-assisted colonoscopy.
Hello, everyone. Hello everyone. It's my honor to show you the colonoscopy inspection examination with the AI assistance. This AI system is developed by a Chinese company named Shenwei Tang. Yeah. 为什么我看不到那个？要不然在后面。
发现系统在右后方。
对，后面为什么我看不到？
你不需要看了，就是说你待会。
那我怎么去介绍呢？
没有，待会有并键的话，你先进镜，进镜以后你就是要显示它最近有多长时间，显示它那个模型，知道吗？进镜花几长时间，最近花多长时间？咱们这个。
The purpose of this performance is to show how the AI will show the information of the suspected lesions in our colon.
比如说进镜耗时耗几分钟，最近耗了多长时间？你解释一下。
As you can see on the screen, there are 3 parts of views.
打一下回镜里，等会打一下，然后打一下回镜里。等什么？你等会打一下回镜里。
For this patient, the colon preparation is very good. Okay.
Dr. Zheng Liu, do you think that AI colonoscopy will help to characterize diminutive colon polyps?
I'm sorry?
Role of AI colonoscopy in characterizing diminutive colonic polyps.
他说什么？
然后你那 AI 系统是不是可以帮你就是么找到那个immunity 的那个
什么叫 immunity？
我这里没搞懂。
For the AI, if you have for example, if you can see a polyp, the AI will there's a sign on the screen, maybe a column, a box with some color, or maybe with yellow or green or red, depends on the grade of the lesion. If the suspected subject is judged as malignant, maybe the box will show the red, will show as red box. So far we cannot see.
You have to understand, by the time being, most of the AI developed for the colon are developed for detection.
Yeah. It can record the time you spend on the examination, during the examination.
Yeah. Yeah.
Especially for the withdrawal time.
Yeah. Characterization will be a next step. By the time being, with AI, we improve the detection, we record, and we use, in that case, the BLI in order to assess with a nice classification or genet classification. There are some not commercially available tools in order to make the characterization, the diagnosis, but is not yet available. By the time being, the first step of AI on the colon is for detection.
Yes.
Yeah. That's correct. This patient is she's only
30 kilogram. So some. Now I think we are at the across.
Professor Liu Jing.
Yes.
I have a question. What do you think? I think which mode do you think do you usually use to detect the polyp? Which mode? If you use the
For the routine screening, we usually just use white light, and sometimes when you depends on the syndrome of the patient before the examination, I think. For the young people and with no suspect malignant disease, we use the white light commonly. So if the patient has some bleeding in the colon, or for the old people, when we withdraw the scope, I think sometimes we use the BRI or NBI to do the examination, especially when you detect some lesions during the operation.
Okay, someone think the NBI and the BRI is easier to find the polyp.
But I don't know. I think, in my opinion, I think the most important part is the white light.
Yes,
white light view. I think, yeah.
I agree, because when you use an intelligence artificial tool on the colon, you should use white light, or you could use the LCI. If you use a BLI, the artificial intelligence don't work, because it's a totally different aspect. And you could see we have some squares, some green square here. If you switch from white light to BLI, it will not work. If you switch from white light to LCI, it will work.
Yeah, correct. I think if you want to use the color, the special light, I suggest use the LCI. That's better.
Yeah. And what is important is to use for detection, you use the artificial intelligence with white light or LCI. And when you detect a lesion, then you switch to BLI. And BLI allows to characterize the lesion.
I agree. Yeah, I agree. Quite agree.
But I saw a lot of green square in your software. Is it
actually
or real polyp?
Could you repeat it again?
Yes, I see some red, some green square. Sorry.
Yeah, green.
Is it polyp or false positive?
If it is showed as a green square, that means the malignant possibility is very low.
Yeah.
If you show as a red square, that means it's maybe a the high risk lesion there. So if you can judge the grade of the malignant grade of the lesion by the color. Now we are at the cecum.
Yeah. And one point is important, and I told for my Egyptian friend, when you do artificial intelligence, you need to have a totally clean column.
Yeah, that's very important. It's the first important thing before the examination. Yeah. For the AI detection, we need to stop at this part of for several seconds. Then the AI system begin to calculate the pullback time. From this moment, it will start to count how long we spend when we pull the scope back.
Yeah.
Now we are entering the ilium ilium, yeah. Yeah, it's very nice mucosal. Please take a picture here, and I will draw back. Well, as we can see, there's a polyp here, right? See?
Yeah.
I'm not sure because I cannot see the AI screen, so I'm not sure what you can see on the screen. For this,
Yes.
for this I'm getting close and close until it show very clearly.
Definitely the
So,
polyp.
yeah, if you can see.
At least nice two classification
Yeah.
polyp.
For
the AI system just like set up the reminder for the middle risk.
You can see this is a one. This is a type 1P, right?
Type 2.
Type 1P. And you can see from the white light, the pit is like, yeah. And I will, from this moment, I will change the light. Oh, I'm sorry. Here. If you can see the LCI, this is a LCI.
Yeah.
Yeah, and I'll change it into the BI and I'm using some. I'm sorry, the genetic type is type 2A maybe.
Yes, and genetic classification is 2A.
Yeah, type 2A, yeah. And I can, later I'll go further to do the magnification.
Yeah. Magnification is very important to distinguish from 2A from 2B.
Now we are using the magnify.
Yes.
So,
you see the regular pattern.
Yeah.
The vessels are regular too, so it definitely is nice too. And on Jeanette is a 2A.
Yeah. The pit pattern is 3L, I think.
Yeah.
Yeah. And you can see here and here. It's an enlargement of the vessel in the middle.
Yeah. But you know, it's 2A. Definitely 2A.
That's 2A. All right.
Yeah. So the shape of the pit is like brain. No, I'm sorry.
Pit 分型是多少？它是 pit 分型是多少？
3L. So it is adenoma. Yeah.
Yeah.
Yeah. Okay. Let's go. Yeah. Come to the
normal.
Normal. Yeah, normal mode. Yeah. So for this we finished. And I'll go. Okay. Later. 现在 OK。Next, I'll do the EMR for this patient. The AI, as showed by the AI system, you can see the when I get close, when I get close, and the AI show the red square. and in the middle. That means it recognizes the lesion and to mind you, it is, yeah.
It's a middle risk.
It's a middle risk lesion. And for the outside yellow square, it is for your side view to remind you by the side view.
这表示癌的东西啊，什么的都不可能。
我会计算这个点，再后来我他说一个，后来我就直接他说我说你干脆要不我们就演示的时候直接说成是肿瘤的风险，但这不是肿瘤的风险。
他说息肉的风，就息肉的那个危险程度是吧？
Let me do it.
放松。
回一点，气，然后接着他的肌肉回一点，真回一点。
漏了。
抱着可以，收回来下来。对，快一点的，对。哦，对，继续，打，我先打一下再打，对，
漏了。OK， 漏了。
他那个皮可能破了，搞不好打不下来。
Maybe I change another side.
他是不是可以换个位置打？
换一个位置的。哦，sorry。
可以了，你们打起来了，可以了。
不行，太那个，再打一下。
打那个上面。
你说 I'm injected the water to separate them.
I'm doing the submucosal injection to lift the lesion up.
Professor Liu Jing.
Yes.
I have a question. When will you use the cold snare to remove the polyp?
Do you mean what did I use for the submucosal injection?
No. When will you use the method of cold snare to remove the polyp?
Method of
we have two ways to remove the polyps: hot snare and cold snare.
过不去，他现在这个矛盾运动。I'm sorry, I'm not very quite understand your question actually.
有两种模式吗？它有两种模式可以切吗？啊？它不是有两种模式可以切吗？我没看懂它是。
EMR 或者是对 ESD。他是问你什么时候做 EMR， 什么时候做 ESD。
When the lesion is.
No, not this question. When will you use cold snare to remove?
Cold snare, right?
Yeah.
For us, if the polyp is less than 5 mm, maybe we just use the cold.
就是不打水电，直接可以。
Yeah. For the lesion below.
热切是为了避免出血。
To avoid the bleeding, we will choose the heat model 还是什么？是热切。
If the lesion is larger than 1 centimeter, so we just use the hot snare to avoid bleeding. Yeah.
沿着往前送，
哎，OK, click, click, click. Since there's some bleeding there, so I make the.
Was it necessary to try a clip for this case? So it was very nice and doesn't need clip.
这夹子怎么说？我忘记了。但是你做的挺好的，就是。Thank you.
Was it clip the case after polypectomy here?
Dr. Lee, would you think that it was better to use cold snaring for this polyp?
Yeah. 那你用那个什么 hot snaring 是不是更好一些 ？I'm sorry. 什么 hot snaring 是什么？哦，就是这个冰冻会好一些。你这个。上次你是用什么 cold freezing 还是什么更好一些？
冷切啊。
Cold, you mean?
他说冷切啊。或者是冷切。你刚刚用的热切吗
Yeah.
你他说你冷切会更好一些。
Maybe if we, as I said, if the lesion is about maybe under 5 mm or less, we can use the cold snare, I think.
It is important to understand small lesion. You should use cold snare, not biopsy, because in the past we used sometimes biopsy. And
not biopsy.
From pathology point of view is not nice. So small lesion cold snare, and when it's a larger lesion like that, you could use ESD mucosectomy.
Yeah, that's what we just do for the common work. Yeah. We are now in the transverse colon. Actually, you can see a bar on the screen. Sometimes you can recognize the change of the bar. That means that is recording our pullback speed. If we use the speed in the green color, that means it's okay. It's not too fast. As in the guidelines, we need to make sure the pullback time no less than the 8 minutes. We are in the sigmoid. How many times did I take? The sensitivity of this AI systems is very high, but sometimes it cannot distinguish the normal mucosal folding from the real lesion. So sometimes for the normal mucosal, sometimes it also remind you maybe that is a suspect lesion. I think that, what's this? Okay.
Professor Liu Jing, you can continue your procedure, and we will move to another room.
Okay, thank you. Thank you very much.
Thank you for your demonstration.
Thanks.
Case number 4. This is a 34 years old female patient. Chief complaint is heartburn for 1 month. Previous medical history mastitis for 2 years. The diagnosis is reflex esophagitis. We will do magnetically controlled capsule endoscopy, and it will be performed by Professor Liu Qingge and Professor Juan Zhou.
Hello everyone, I'm Dr. Ge from Zhongnan Hospital, Wuhan University, and this is Dr. Zhou. Today we are going to show the process of the magnetic control capsule gastroscope. We will use this little handle to control the position of the capsule. Dr. Zhou will show us later, and now let's do the preparation first. Dr. Zhou is asked the patients to drink some water. And just now we have connect the equipment and connect the data cab. Now the patient has drinking about 700 to 1000 milliliter water. Are you ready? Now, Dr. Zhou is ask the patients to on the left side position, and we can see the light of the capsule is swing, and we are ready to swallow it. This capsule is made by Jinshan Technology Company in China.
We need to have a screen. Okay, thanks.
The patient puts the capsule into mouth and drink some water. We can see the vision very clearly. And now we can see the esophagus image. Okay, we can see a lot of water and a little bit of mucus. Now the capsule have come to the stomach. I think it's fundus. We have do the preparation for almost 2 hours ago, so there's a little bubble. Usually take the deformer 40 minutes before swallowing the capsule is suitable time. There's a little polyp. Can you see it?
Yes, perfectly.
It's very clear.
Of course, it's hyperplastic polyp.
I think it's body. The little curvature. Do you agree with me?
Yeah.
Dr. Zhou will control the position of the capsule by moving the handle. Make it near the mucosa or far away from it. The observation will from the fundus to the body, then the angle, entrance, then the last is pelvis. We can see it's very clear because she has drink a lot of water and the stomach cavity is big enough for us to see the picture. A little mucus. We can see the folds. I think it's the greater curvature.
Are you moving the patient to see the antrum?
I'm sorry, can you say that again?
Are you moving the patient on the back to see the antrum? Because now you are in lateral position.
The patient now is on the left side.
Yeah.
Then the position of the patient can change to show different position of the stomach. Dr. Zhou will show us later.
Okay.
Now the patient has lied down.
Dr. Zhou, you can move the capsule forward and backward only, or in all directions?
Can you see the cardia?
Yeah.
This picture shows us the cardia very clearly, and there's a little white mucus near it, near the cardia. The cardia is so clear in the middle of the picture. Dr. Zhou will ask the patient to drink some water, and we can see the water comes through the cardia. From this way, we can see the open or close of the cardia. The movement is normal.
Dr. Zhou, don't you see that the picture is dim? It's not clear picture. Can you reach to a conclusion by such a picture?
Oh, okay. 他们想近一点. We can get closer. Just give us some seconds. 看近近看cardia. Now we can see the camera is much more near the mucosa. And Dr. Zhou is trying to change the position.
You have to understand, depending on the magnetic force, the capsule could be, moving on the surface of water, or the capsule could be down next to the mucosa. It's when the capsule is next to the mucosa, we have the same resolution than the gastroscope. Not last generation gastroscope, but routine gastroscope from 10 years ago. And Jensen are developing also a robot where all the gastric examination are performed by a robot, but it's still under development.
The movement of the capsule can be influenced by several factors, such as the weight of the patient and the water she drink. I think the patient has drink enough water to make the capsule move smoothly. Another little pillar. And we can see the rack very clearly too. I think it's moving towards the cardiac. In the proceed, we can communicate with the patient, ask if she has any incompliment. Usually, she can feel nothing. Okay, it's the cardio. I think today it's the nearest position we can get, but I think it's clearly enough. Are you satisfied with this image?
Yes, it's a good image.
Okay.
Could you show us now the antrum and pylorus?
Show what?
The antrum and the pylorus.
Antrum, okay. Antrum and pylorus, we will show it. 好，可以到胃窦。他们要看胃窦，胃窦幽门、胃角，可以往下走了。Can you see the angle?
Yeah.
And Dr. Zhou asked the patients to drink water because the fold is too deep. We want to drink some water to expand the cavity.
Yeah. But to see the antrum and the pylorus, the best is to put the patient in lateral side, but right lateral side. By moving the patient, you can see much better the antrum.
Yes, the right side. The right side is a useful position to observe the entrance and the pelvis.
Now you could see the air-water surface.
Yeah. I think it's clear vision of the entrance and the pelvis.
Exactly.
And just now we can see both entrance and fundus in the position in the special position. Mm. Mm. The patient has sit and we can see more clearly vision of angle and the body. Drink some water. The angle is very clear. And I think the mucosa is smooth, no reddish, no erosion. Mm.你现在在看微角吧？微角你刚才看了。你现在在看什么？啊。嗯。This picture shows us the whole stomach.
Could you show us where is the magnet?
Just now is the far view of the stomach, and now Dr. Zhou will show us the near view. The battery of the capsule can maintain about 4 hours, so it's enough for us to observation the stomach, maybe a little small intestine. But if we want to see more and more, we should do the intestine preparation first. But this patient didn't do the intestine preparation.
Dr. Joe, what do you think about the diagnostic yield of such a procedure? And what's more easy to do, upper endoscopy or to do the capsule endoscopy?
I think the movement is not so smoothly as the normal upper GI examination, but it can be useful for the old people or some person don't want to do the normal upper GI examination. But the vision, the image we get is as clear as the picture we get as we do the normal upper GI examination.
But don't you think that you can miss lesions by this procedure?
Can you say that again? I'm sorry.
The accuracy, the diagnosis accuracy of this gastric guided capsule is about the same than the routine gastroscopy. We did the first clinical study 10 years ago with a capsule from Olympus Siemens, and we clearly show in nearly 300 patients that the overall diagnosis from a capsule is exactly the same that the gastroscopy. And in some cases, the capsule is able to diagnose small abnormality. In some cases, the gastroscopy diagnose over abnormality. But the overall diagnosis here are very similar. But it was, we compare with a scope 10 years ago. It was not high resolution scope.
Thank you.
And this capsule guided is very popular in China. More than 200 hospitals are using gastric guided capsule, especially because China is a huge population and the number of gastroenterologists is not so high compared to a population. So that means that kind of examination could be carried on by a technician.
Yes.
The procedure will take the time of the procedure.
About 20 minutes.
Procedure or can be short procedure?
No, when a study we done about 15 to 20 minutes. It's longer than gastroscopy.
Actually, Dr. Zhou has finished the procedure, and we usually do the procedure in less than 30 minutes.
Yeah, agree.
Okay, thank you.
Thank you.
Should we move to the AUS demo 1? Yes, because we are short of time. Yes, we can go for one of EUS demo cases.
Yeah, the next case is EUS.
Dr. Fang?
The next case. So we are done here. We will show you the next case.
不是我们这边是吧？
应该是吧。
Thank you. And we can see very clearly with high resolution of the capsule. So we'll move on to the next case.
Okay, case number 5. This is a 56-year-old female patient. Chief complaint, intermittent abdominal bloating for 3 months. Previous medical history, no significance. The diagnosis is colon LST polyp. Endoscopy showed LST polyp on ascending colon. The size is about 2 + 2 centimeter. Procedure ESD, and it will be performed by Professor Ying Chang.
Okay. Okay, can you hear me?
Yes, Professor
Okay.
Chang.
Okay, now we can see the lesion. The lesion is located in the ascending colon near the cecum. This is the cecum. So I think the size of the lesion is about 2 centimeter. And we can see this is a naturally spreading tumor. We can see the pit pattern. I will change it to BLI. This is not a magnifying endoscopy, so we can see it, but we almost can see the pit pattern. And this is type 3 or 4 pit pattern, which indicate the adenoma. So sometimes we need to mark the lesion, but I think because the lesion, the margin is very obvious, so we can do the ESD directly. We don't need to margin the lesion. Okay, injection. And I think I should put the lesion in the 6 o'clock. Maybe this is more comfortable for ESD.
What will you inject into the submucosal layer? Just the saline or something else?
Sodium hyalurate. Yeah. I always forget the English words. It's too professional. It's too professional. Get out. Okay. Okay. And usually we inject as much as possible at the first time. Okay. Okay,
the margin is very clear.
Very clear, yeah.
So we don't do the marking yet.
Okay. Okay, need out. Okay. Oh, okay. Okay, left. And the first step is to mucosa incision. Mucosa incision? Oh, okay. Okay. There. Yes. Okay. 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 Okay, need out. Okay.
The knife is dual knife?
Yes, dual knife.
And the length of the tip of the knife is 1.5 millimeter or 2? millimeter?
It's almost 2 centimeter. Yeah.
2 millimeter.
Yeah.
Okay. I usually use the 1.5 millimeter to do the colon
Yeah.
ESD.
Okay.
So
Okay,
first
we
you
will
do the circumferential cut of this lesion.
now we can see the submucosal layer, and we will cut the submucosal layer at the lower third layer.
Dr. Shang, can we use a tip of bulobectomy snare to do such a dissection?
Maybe, but I think do ESD, the margin is more clear, so you can make sure you dissect all the entire lesion. And now I can see the vascular. I will use the coagulation to pre-coagulate the vascular.
What's your advice to avoid post-procedure?
Sorry, can you repeat the question?
Your advice to avoid post-procedure bleeding.
Because if you bleeding, it will make your view mess. After the operation, you mean? 他是说我预处理有什么好处吧？
Coagulate or visible blood vessels in the field.
怎么样去预防术后出血？
术后出血吗？
对对对，怎么去预防？对。
Okay. I think it's a good question. And after the procedure, we did to coagulate all the visible vessels. And now we can see this is the vessel, and I use the coagulation. And okay. Sometimes we need to make the needle out so that we can avoid to injure the muscular layer. So the best way is to enter the submucosal layer so that you can see the submucosa more clearly. Now we can see the vessel, and we need to coagulate.
Now the submucosal layer is dissection, and I think you can use the cap to push the mucosa, then show the submucosal layer clearly, I think.
Yeah, that's right. Usually we cut the right side or left side first, and make the cut like a U shape, just like a U. Okay. Now we can see the white muscle layer. This is the muscle layer. Maybe we need to inject more. Inject.啊，我知道。这个图像怎么老是不清晰？啊。OK， injection。OK OK。OK injection。OK。OK OK。OK less。Although I think I cut the entire lesion, but maybe this margin is too close to the lesion. But I'm sure I cut the whole lesion. But okay. And we can see a vessel here. Coagulate the vessel. Okay. There is a little bleeding.
Professor Chang.
Yeah.
Because of the time limit, we have to close this session. Very well done.
Okay,
You
thank
can
you.
continue to finish this procedure. Thank you.
Okay, thank you, thank you.
Thank you.
Thank
So
you very
now
much.
we have to